So moving to the entity of borderline resectable pancreas cancer, and this group of patients is characterized by having no metastatic disease, but having either arterial to a lesser extent, or more typically venous involvement, where there's a high probability if that person went to the operating room, they would have an incomplete resection with a probability of at least a positive microscopic margin, if not a potential for gross residual disease, which from the oncologic perspective is not a desired outcome. So there's no consensus yet, and there's no randomized data to define what should be the optimal paradigm for patients with borderline resectable pancreas cancer. It probably accounts for about 15% of all patients. But increasingly, it's recognized that an upfront systemic approach with or without radiation is an acceptable way to proceed. And a current NCI study has completed its pilot phase, which will provide a potential control arm for a future randomized study. And that's the Alliance study in borderline resectable pancreas cancer, which looked at initial FOLFIRINOX, followed by capecitabine-based radiation, and then surgical resection in about 22 patients. And these data will be presented at ASCO in 2015. And at the current time, the field is sort of defining how to take these data forward. So moving to the setting of locally advanced disease, so about 30%, 25% of people with newly diagnosed pancreas cancer will have localized but inoperable pancreas cancer, again due to major arterial or venous encasement and without distant disease. And these patients have stage 3 disease. And the approach has evolved. So increasingly, systemic therapy is a standard of care for patients with locally advanced and unresectable pancreas cancer. And we had data relatively recently from the LAPO-7 trial from Europe, which was conducted in locally advanced unresectable pancreas cancer patients and was designed to answer 2 questions. There was randomization initially to whether or not erlotinib was going to be added to gemcitabine, and second randomization to whether or not radiation was going to be included, so mirroring RTOG 0848 in the adjuvant setting. And in fact, this is why erlotinib was dropped from the adjuvant setting. This study showed that there was no benefit to the inclusion of erlotinib, and in fact it may even have been a little bit more toxic for patients. But the outcome from the radiation question is potentially practice changing in that it didn't show an advantage to the inclusion on a routine basis for chemoradiation for patients who hadn't progressed after 4 months of systemic therapy. It's also important to note, though, that it didn't show any detrimental benefit either. And further analysis have suggested that for people who have had pain, that their quality of life may be better when radiation is included. And ongoing analysis will further define whether there are additional subsets of people that can be identified whom are most likely to benefit from radiation. One other point to make about this study, and it's a very important study in the setting of locally advanced pancreas cancer, is that it didn't use IMRT-based radiation, which has become an emerging standard, admittedly not with randomized data, but there are some questions whether that's the results of LAPO-7 apply across the board. And it also doesn't address other emerging techniques of radiation, such as SBRT, or stereotactic high fractionated doses of radiation, and where that fits in pancreas cancer. And that may be a more palatable option for patients. One, it's a shorter delivery time frame, and usually, at least in the short term, the side effects are more manageable for patients. So for locally advanced disease, the 2 current approaches, systemic therapy on its own with multi-agent cytotoxics, or systemic therapy followed by chemoradiation. There's a couple of important studies, and I'll just mention one that is underway in North America, RTOG 1201. and it's using a backbone of gemcitabine and nab-paclitaxel. It's a randomized phase 2 trial that will look at the addition of standard chemoradiation after a combination of cytotoxics, which differs from LAP07. A second arm is looking at an intensified dose of radiation, and there is some data suggesting in certain patients that may be of value. And the third arm will be a chemotherapy alone. So we'll get some hints of a comparative assessment of systemic therapy versus systemic therapy and radiation in the locally advanced setting.